On behalf of Rainbow Children's Hospital and the organizing committee, I welcome each one of you to this first conference on cytokine storm in children. We are pleased to let you all know that we've had close to 2,000 registrations for this event, which will be held over 3 days. And before I move forward, so as you all know, we lost two very big stalwarts in the field of pediatrics, Dr. Hector Wong, who's a pediatric intensivist at Cincinnati Children's Hospital, and Dr. Rolando Simas, who's the head of pediatric rheumatology in Florence, Italy. So we dedicate this conference to both of them who have done a lot for research in the world of sepsis and cytokine storm, and we'll always remember them for their great work. So before I move forward, just a few housekeeping rules. Apart from the speakers, I request all of you to kindly keep yourselves on mute. Please post your questions in the chat box, and the chairpersons or the moderator will take it up at the end of every session and every talk. Alternatively, you can also post your questions on YouTube if you're watching it live from there, or also on Twitter and the Telegram live discussion group. We will take all the questions from there and post it in the chat box here. And please actively participate during the conference so that you gain maximum benefit from this event. We have a fantastic line of speakers, and we have been very fortunate to have all the stalwarts join us from across the world today. So I welcome each one of you, and I now request Dr. Akshay to provide a brief overview of the program today.
So good evening, everyone. I'm Dr. Akshay Shetty. I'm a pediatric intensivist at Rainbow Children's Hospital. On behalf of the organizing committee and Rainbow Children's Hospital, Bangalore, I extend a warm welcome to all the delegates from India and across the world. Now, reason for creating this event essentially born out of the need of saving really sick ones in ICU, especially those ones with the multi-organ dysfunction. We all know that despite the available protocols, there are certain set of patients with multi-organ dysfunction who die despite of the best efforts. If anything good can come out of this COVID pandemic, it's probably the understanding of the role of immunomodulation. Now, simple things like dexamethasone has saved countless number of lives during this COVID pandemic. And for us, all of those who work in Indian context, subcontinent, the multi-organ dysfunction predominantly happens in the context of tropical diseases like dengue. One of the aims of this meeting is to explore the role of immunomodulations in many of these tropical conditions like dengue and see if we can do better from what we're doing now. We've been incredibly lucky that we've been able to get global experts who have done innumerable amount of, who has done a phenomenal amount of work in the field of immunomodulation. Despite their busy schedule, they have agreed to join. We extend a deep gratitude for taking their time and attending this event. Now, this event is unique in the sense that it's purely multidisciplinary. We have both intensivists as well as rheumatologists discussing on one particular topic, that's cytokine storm. So we've designed program in such a way that we want to decrease Zoom fatigue. So we've extended it over 3 days, trying to cover most of the relevant aspects, practical aspects when it related to cytokine storm. We hope all the delegates who are attending to participate actively, like what Dr. Chandrika mentioned, post their questions in the chat box or on the YouTube or on Twitter. And we really hope to take them up at the end of each of those talks. At the end of every day, we have a case discussion. The idea behind case discussion is to bring out the practical nuances about managing immunomodulation in very sick children. And we don't want it to end as just a theoretical discussion. So with this, I welcome all of you for this meeting, and I really hope this meeting meets the expectation, meets your expectation over the next 3 days. It's my privilege to welcome Dr. Dinesh Chilla. He's a director of pediatric intensive care services of Rainbow Children's Hospital across the country. So I would request him to provide a welcome address and invite the chairpersons for the first session. I think you're on mute, Dr. Dinesh.
Thank you, Akshay. Good evening, everyone. And first, on behalf of Rainbow Children's Hospital, I take this opportunity to invite you all to a fantastic conference. And I take this opportunity to congratulate both Dr. Chandrika Bhatt and Dr. Akshay Shetty for designing such a nice program. And as I said, to avoid a Zoom fatigue, to sort of put it over next 3 days and actually get some meaningful discussion over the 3 days. As an intensivist, we all know that, and this is, COVID has made certain things more popular, and one of them is, of course, the cytokine release syndrome. Many of us did face during managing dengue fevers and other things, the challenges of differentiating between hyperferritinemia versus cytokine release syndrome. What is the right modalities of treatment? And many of times we got stuck with it. And fortunately now there's a good sort of understanding and multidisciplinary approach between a rheumatologist and pediatric intensivist. And that is something which this program has, that we can probably treat better some of these very sick children by collaborating with specialists who understand this better and probably choose the right medications for these children. Now, I think over the 3 days, the program has been sort of very nicely designed, which actually facilitates discussion. And the program is as good as the speaker. And I think they both Rakshay and Chandrika have done a great job of getting great international experts and the national experts who could sort of, who are not only experts on these topics, but who could also initiate good discussions and who have great experience in managing such situations. So without wasting much time, I sort of welcome you all and hope it will be a great sort of scientific discussion. And I'm sure we'll have some great learning points at the end of this meeting, and we should be able to save some more lives with this. I take this opportunity to sort of introduce two of my very good friends. I think for all those from India, we don't need to sort of enter the very well-known figure, Dr. Ramanan himself, the chairperson for today. He is a medical director and head of Department of Pediatrics at Kanchi Kamakoti Child Trust Hospital, and is honorary pediatrician at Southern Railway Headquarters Hospital, Chennai. More than 100 index publications and nearly 600 CV sessions with 10 orations. Distinguished TNB teacher awardee from NBE. People love to attend his classes. He's got a Lifetime Achievement Awards from Tamil Nadu MGR Medical University. He has been a chairperson of the IIP Infectious Disease Chapter, and he's an advisor for ACVIP from 2020 to 21. And my good friend, Dr. G.V. Baswaraj, and he's the most popular person across the country, who is currently the Honorary Secretary General of the IIP 2020-21. Currently the Professor of Pediatrics and in charge of the PICU at the Indira Gandhi Institute of Child Health, Bangalore, and a course coordinator for fellowship in pediatric intensive care. He has been the founder secretary of the IIP Infectious Disease Chapter, Karnataka, and the chairperson of IIP Intensive Care Chapter in 2020, and been the convener of Scientific Committee of Pedicount 2017-18. He had the FIP Award in 2017 and also awarded the Dr. B.C. Rai Award by IMA Karnataka in 2020. So off to two eminent and distinguished teachers, Dr. Bala sir and Dr. Baswaraj, off to your sessions.
Can we start, Dr. Chandrika?
Yes, sir, you can start.
Sure, sir, please do.
Yeah. Thank you, Dr. Dinesh. But when Dr. Chandrika invited me to chair this session, I was terribly worried because I know very little about this CRS. In fact, I want to call this COVID reinvented syndrome. Actually, cytokine release syndrome has been reinvented by the rheumatologists, and then they have passed on to poor general pediatricians like me. But when Dr. Chandrika invited me to chair this session, I was terribly worried because what's happening? Yeah, am I audible now?
Yes, sir, you are.
Yeah. So I want to call this COVID reinvented syndrome, which has been passed off by the rheumatologists to the intensivists and then to poor general pediatricians like me. In fact, we have 3 interesting lectures during this session. The first one is by none other than my close friend, philosopher and guide, Professor A.V.Ramanan, who, of course, doesn't need introduction even to an international audience consisting of pediatricians and immunologists and dermatologists. But then I have to follow the protocol and introduce him appropriately. He's the professor of pediatric rheumatology at the University of Bristol, UK. After his training in India, he left for UK and has climbed the ladder in pediatric rheumatology very fast. And he's well known for his research work in uveitis, cytokine release syndrome, macrophage activation syndrome, hemophagocytic lymphohistiocytosis, and now of late in COVID-19. And he has been involved in several research projects across the world related to rheumatological and infectious disease related problems in pediatrics. And it's my great pleasure to invite Professor Ramanan to start this conference with this session. Over to Professor Ramanan.
Thank you very much, Dr. Balsubrahmanyam. I'm going to try and share my screen first, and then that's okay, isn't it? So you can see the screen fine?
Yes, we can, Ram.
Yeah, that's great. Thank you very much for the kind introduction. It's an amazing conference with an incredible list of speakers that has been put up, and it's an absolute pleasure to be starting off, but it's also an incredible challenge because Chandrika, who I thought was a good friend, has given me probably the most difficult topic. She says define cytokine release syndrome or cytokine storm syndrome and a host of things. So I'm not going to answer many questions. I'm going to raise more questions than I'm going to answer, and I'm going to try and set the scene, as it were, which has already been touched on by a load of people. And you have an array of experts who will try and probably answer some of the questions I raise. I make no apologies for some provocative statements that I will make on an academic platform, but that's just to set the scene for greater discussion, as has been highlighted. So it's certainly something which has cropped up in the last couple of years, as been mentioned, because of COVID. But some of us who have been working in this area have always recognized that there is these conditions called by different people. The oncologist used to call it cytokine release syndrome in the context of CAR T-cell therapy, and I'll come back to it. And then in the context of COVID, the term cytokine storm syndrome took relevance, which hitherto was focused on small groups. And then you have the hematologist oncologist. It's an absolute pleasure for those who don't know that I'm going to be followed up by one of the world's leading proponents and researchers in the world of HLH, Professor Janninge Henter. And then the rheumatologist calling it macrophage activation syndrome. Some of this nomenclature has over the years, unfortunately, done more harm than good, because therapies have focused on different aspects. The hematologist or the oncologist would use things which the rheumatologist wouldn't. The rheumatologist would use things which the oncologist wouldn't. And then you had the CRS specific therapies, and then you had the COVID associated cytokine storm syndrome, whether it exists or not in all its profoundness in all of the patients, but it certainly shed light. As I always say, you know a condition's arrived when the New England Journal of Medicine does an editorial. So certainly, as someone alluded to, not just New England Journal of Medicine, but I think even the lay press, such as Wall Street Journal and New York Times, in the height of COVID, started talking about cytokine storm. Not always in the right context, but as they say in the world of PR, all publicity is good publicity for this condition if it does some good for the patient population who are critically ill. So as some colleagues have pointed out, you can see this in a wide variety of contexts. And that's why you have pediatricians, you have intensivists, you have infectious diseases specialists. So you have these, and I'm going to use the term cytokine storm syndromes because I think it's far better at encompassing everything rather than cytokine release syndromes. But I think the terms are interchangeable and the name is not what's crucial. But what you have is in the context of ARDS in the intensive care, and I think it's interesting, someone mentioned dexamethasone. 2 years ago, you would never get steroids past an intensivist, be it in an adult or a pediatric intensive care unit. And at last, we are coming to the recognition that even in infections, what kills you is not the bug itself, but the inflammatory cascade of cytokines that is released by the infective agent, and I'll touch on that more in this talk and a bit more in the later talk. And of course, we have malignancies, particularly anaplastic large cell lymphomas, which can present as in this multi-organ dysfunction cytokine storm syndrome. The infection sepsis associated, over which I think some of the cases are going to focus. The one we all recognize most is EBV HLH, which has been there for a couple of decades. But what's brought all of this attention to this condition, as has been mentioned by me and others, is COVID-19. And of course, the prototype autoinflammatory condition, where we've long recognized a form of hemophagocytic syndrome, which is Still's disease or systemic onset juvenile idiopathic arthritis. But let's look at this picture from the NEJM, which I've taken the liberty of showing you, which describes the pleiotropic manifestations of cytokine storm syndromes. And you can have neurological manifestations presenting as confusion, hallucinations, delirium, a host of systemic manifestations, hepatosplenomegaly, which we all recognize, manifesting either as cytopenia and coagulopathy, which is the prototype, particularly in the DIC context, or disseminated intravascular coagulation. Terms such as multi-organ dysfunction syndrome, systemic inflammatory response syndrome, disseminated intravascular coagulation used to be thrown about in ICUs, but they are not really syndromes which are descriptive of the pathology rather than actually being diagnostic terms. Occasionally, they get confused as diagnostic terms. In UK, you wouldn't get a bed unless you have multi-organ dysfunction in an intensive care. So this is just showing the absolute pleiotropic manifestations of cytokine release. And this is just another cartoon further focusing. And if you look in the lungs, at least in COVID, we've speculated that there is probably a picture which is organ limited. And certainly people have recognized CNS HLH, which is very difficult diagnosis to make. And I think COVID is an example of organ restricted cytokine release. And then you will have kidney and liver. And certainly there are HLH presentations which are focused exclusively on the kidney. The vasculature and the lymphatic system is what we all recognize. And there are a host of other manifestations to do with rheumatic diseases, which we can touch on and is going to be covered. But what's interesting in the pathophysiological features, which again is from this is review, you can see that they talk about these iatrogenic causes, and we'll come back to this, which is the chimeric antigen receptor T cell therapy, which has really revolutionized certain forms of malignancy, particularly leukemias. And then you have the bacterial infection, EBV is a prototype, and then either perforin defects or perforinopathies, or the secondary HLHs, which may be autoinflammatory and then oncology driven. And what you have is an activation of T cells. I make no apologies for talking about immunology, which I'm going to do for the next 10 slides, because you cannot have a conference on cytokine storm and not talk about immunology, both innate and adaptive, and the cytokines. And what you really have is a hyperactivation of the immune system. And this can either be driven by the innate immune system. There is no extraneous trigger, and that is characteristic of the autoinflammatory conditions, as well as some of the perforinopathies, or it can be through the adaptive immune system. And we believe that it might even be a complex interplay between these two. If you take certain infections such as EBV, which is fairly ubiquitous, why is it that only some patients with EBV go on to develop HLH and not others? But what you have really, as has been mentioned, is this ability to intervene in the cytokine storm. So we now have molecules which inhibit interferon gamma, which is now an approved therapy for primary HLH. We have anakinra, which you will hear again and again, an IL-1 blocker. We have IL-6 blockade, which has now become standard of care in the management of COVID. And you have steroids, which are more a blunderbuss approach at suppressing the cytokine cascade. And there are only 3 drugs in COVID-19, which has been approved by WHO or advocated by WHO, and that is steroids, tocilizumab, and baricitinib. So really, the emphasis on understanding the cytokine storm in the context of these patients is because we now have several targets which we can individually target with these molecules. So let's look at these. The CAR T-cell therapy as an introduction is in oncology, mainly in leukemia, which is infusion of the patient's own chimeric antigen receptor T cells to target the tumor cells. And when you have a cytokine storm from this, the standard of care happens to be tocilizumab. And that's where the tocilizumab use in COVID came about. And then you have certain specific molecules which target CD19 and CD3 specific T cells. And again, the treatment for that cytokine release syndrome is using tocilizumab. For EBV HLH, which is very interesting, people always use rituximab, which is mainly driven by gamma interferon TNF. We have bacterial sepsis, which is quite heterogeneous, and there may be a host of drivers. And the management so far has resulted in just managing with supportive care and antibiotics. And of course, with steroids, we spoke about, with COVID, we've spoken about the role of steroids, IL-6 inhibitors, as well as more recent approval for JAK kinase inhibitors. But if you look at a different context, primary HLH, which we've been working for 20 years, and Dr. Henter is going to talk more about this, there are clearly identified pathways, the HLH-94 or the 2004 protocols, which he'll touch on, and now with emapalumab. But then you have secondary HLH, which is a mishmash of a whole host of conditions, which is managed depending on which ologist you see, either with anakinra or sometimes with JAK inhibitors or with steroids or with nothing. And then you have autoinflammatory disorders, which can occasionally give rise to macrophage activation syndrome, and which again are variably managed. So there's heterogeneity in presentation, heterogeneity in management because of the heterogeneous nature of different ologists. But let's look at some of those factors which bind or separate these. So if you take familial HLH, mostly you will see these in young children, although there are increasing recognition of older children or even young adults being recognized with familial HLH. You will have high levels of gamma interferon and high levels of ferritin and soluble CD163. If you take secondary HLH, which we believe are heterozygous mutations in some patients, so they are predisposed, but they may need an extraneous trigger, and that might be an infection in this genetically predisposed host. Can happen across the ages. Adult onset Still's disease patients can still get it. Adult onset lupus patients can get hemophagocytic syndrome. And the picture is not too dissimilar to that of familial HLH. And then you have the cytokine release syndrome related HLH or MAS, where we don't know if there are any genetic predispositions. We know that there are some work nicely shown in COVID-19, for example, published in Nature about your anti-interferon antibodies making certain people more susceptible to having severe disease. But the picture at the level of the cytokines is not dissimilar. But when you come to sepsis, certainly there isn't a huge amount of gamma interferon, so that's probably not a pathway that you'd want to block if you want to treat sepsis-associated hemophagocytic syndrome. But for the rest, the ferritin elevation is not as high, not in the tens of thousands or hundreds of thousands as it is in HLH. And this will be explored more by the other speakers. But let's look at CAR T-cell therapy, which is where the term cytokine release syndrome comes. And modeling cytokine release syndrome after CAR T-cell transfer in this nice paper in Nature Medicine a few years ago reveals macrophages to be really pivotal in this process. And no wonder rheumatologists have called it a macrophage activation syndrome. They were just describing what was happening, while the literature is much more clear now. And you can see this working model of macrophage activation, release of cytokines, recruiting monocytes, and then the circulating monocytes were working on the macrophages again. And you have the damage-associated molecular patterns and the pathogen-associated molecular patterns, which might be important in sepsis, and the damage-associated molecular patterns may be more important in those with defects of innate immune system, which then leads to this vascular leakage hypotension, which might be what many of us may see as practicing clinicians, either in the ICU or in our clinic. And again, to demonstrate that the world is changing, we can now have molecules which block GM-CSF. Certainly lemzilumab has been trialed in adults with COVID-19 with some degree of success. Tocilizumab is well recognized now by the lay public even. Anakinra, and we know IL-1 is very neurotoxic. So there is a role for anakinra in all its glory, not just in HLH systemically, but also in CNS manifestations of HLH. Now, The oncologists who have really gone forward with CAR T-cell therapy for certain refractory leukemias and probably even multiple myelomas have a proposed mechanism as well as a pattern of grading CRS. So they say after the CAR T-cell therapy, you have fever and mild symptoms, which is grade 1, which is very intuitive, or when you start having hypotension with organ toxicity, or when you're having hypoxia with significantly elevated liver transaminases and organ toxicity, or when you're really acutely, severely ill with multiple organ toxicities, raised transaminases, and needing mechanical ventilation. I show these as really a prototype for demonstrating the complexity and the grading that people use. Dennis McGonigal, my friend and colleague who's going to speak, I think, tomorrow, and I looked at the immune cartography in this Nature reviews, looking at MAS in the COVID-19 era because of the increased attention. And really what we're seeking to show is this same thing that I've illustrated. You can have classical MAS, which you'll hear a lot from Dr. Henter later on with gamma interferon and other cytokines, which is how we understand young 1-year-olds presenting with pancytopenia, coagulopathy with primary HLH, probably a perforin defect. But you can also have a cytokine storm leading to a capillary leak syndrome, probably something more the intensivists tend to see with infections, or the same with sepsis and multi-organ dysfunction syndrome, or a viral infection, be that EBV, or I'll make a case later on for dengue, which can present in a tiny minority with a DIC and a hemorrhagic picture. And a lot depends on the organ involvement and the role of the erythrocyte. So you can see the effects on the marrow with anemia and pancytopenia, or on the liver with elevated triglycerides, with the abnormal liver function test, which is very characteristic, and the coagulopathy, which often some of these patients who die from sepsis get put down as sepsis, query cause DIC in the death certificate, when really it should be a hemophagocytic syndrome. And it does matter because you can make a difference with immunomodulatory therapy. And in the spleen, the splenomegaly will certainly account for the pancytopenia. And all of this is really explained by this macrophages releasing cytokines, which are then driving this disease process either through the marrow or through the liver or through the spleen. And what you see is a description of a condition which can happen both in the immunodeficiency context. So you have people with either perforin defects, which is primary HLH, or syntaxin mutations, or UNC13D mutations. So classical immunodeficiency, but you also have gain of function mutations, which is probably both converging to give the cytokine release syndrome. So the context is important, even though the final pathway is shared by a host of agents. So you can come in from either a gain of function mutation resulting in hyperactivation of the immune system, or you can have an immunodeficiency resulting in defective apoptosis, as in perforin mutations, resulting in persistent antigenic stimulation of the macrophages, resulting in the final common pathway of release of multiple cytokines, primarily driven by interferon gamma, IL-1, and IL-6. And I think recognizing this pluripotency of approaches for hemophagocytic syndrome or cytokine release syndrome or cytokine storm syndrome is important in getting us all ologists thinking of this in the same function. So we put this picture of thinking of this across the innate immune system boundaries, and these are artificial definitions because we know that there is a lot of crosstalk between the innate and adaptive immune system. But we put this cartoon to show that you can have loss of function with perforinopathy, we call it perforinopathy with primary HLH, you'll hear lots about it later, or gain of function mutations, which we think might be more in certain forms of very rare MAS, such as NLRC4, which I think you'll hear from Scott Canna, lupus-associated macrophage activation syndrome, which in the Indian context never gets recognized. A lupus patient presents with pancytopenia and gets put down as either sepsis or lupus flare, and sometimes they die without getting the appropriate immunomodulation that they should. And then you have the EBV-related lymphoma on one end, again, of the loss of function mutations. And the therapeutic implications, because ultimately this is not about navel gazing and talking about different terms for different conditions and publishing papers, but it's about saving lives in intensive care setting for children who come in acutely ill with multi-organ dysfunction, and for that matter, adult, even though I'm a pediatrician, I can only speak about children. And I think talking about where you target, we can now target IL-18 with a novel molecule. We can target IL-1, IL-6, GM-CSF. There are 2 molecules targeting GM-CSF, gamma interferon, and we may be able to make a significant difference in the survival and in the morbidity of children presenting with these conditions. And again, this is yet another extrapolation of what we show, that what happens at the intestinal epithelium level with the macrophages being activated, or in a lymphoma, or in a myeloid cell malignancy, or through the T cell receptors. And we make the SARS as an example, but that's more organ-specific pulmonary hemophagocytosis, or a pulmonary specific cytokine storm, for want of a better word. And this is what I used to say 10 years ago as a more simple version. You have primary hemophagocytic syndrome, you have acquired hemophagocytic syndrome, which is virus-associated or infection-associated, you have rheumatic diseases, you have malignancies, and then you have immunodeficiency like Chiari or Griscelli. And I don't think it's changed much. There are a few more strands which we now add to this layer. So what is the diagnostic criteria? This is work of Henter and colleagues, which he'll touch on. And I think this is still extremely relevant. Fever, splenomegaly, 2-cell line cytopenia. Perhaps the level of ferritin is a bit too low. Soluble CD25 and NK cell activity are never really something you can get in the real world, certainly not in my experience, and would be much harder in several low and middle income countries. Marrow hemophagocytosis, when it's present, is good, but its absent doesn't exclude the diagnosis. And the organs where you get the greatest success are usually spleen and lymph node, which nobody is willing to biopsy. So let me show you why this is relevant. This is work done by Ethan Sen and colleagues, and I'm going to show the typical scenario is a 3-year-old boy presented to a UK hospital, 2-week history of sore throat, fever, 1 week of reduced appetite, getting admitted with what's thought to be sepsis, now starting to have cytopenia, raised transaminases, coagulopathy with a ferritin, which is almost touching 10,000. And this is the criteria. Now, increasingly, there is evidence to show that a ferritin of more than 10,000 on its own, which is universally available, is highly specific for HLH. What people have done is now look at how many of these cases are being missed in a multi-center audit in UK. So they looked at 8 tertiary UK teaching children's hospitals over a 3-year period and searched all the biochemistry databases for children with ferritins of more than 10,000. So we said if you have 5 or more of the 8 criteria, but if you have 4 or more, so if you have 4 or more of the 5, then that is enough, because it's very difficult in the real world to get marrow hemophagocytosis or NK cell function or soluble IL-2 receptor. So we said we'll modify it for this purposes of saying if you're 4 of the 5 that most people can get, then you have HLH. What did we find in that 3-year period across 8 hospitals? This is unpublished data, but presented at the Royal College of Pediatrics meeting. We found 94 cases, of whom about half of them really needed ICU admission, either pediatric or neonatal. About 1 in 10 was systemic JIA, well recognized, that's fine. There was no major ethnicity that was different from that of the population. And what you see is infections being a big chunk, oncology having a chunk, rheumatological indications, and immunological indications. Interestingly, we found this both nationally as well as locally, that post open heart surgery, cardiac surgery for children with congenital heart disease, you do have high levels of ferritin and some level of cytopenia. Something to bear in mind, that may not always be hemophagocytic syndrome, although we're starting to do work in piglet models of looking at giving tocilizumab for the hypotension that we see post bypass and post cardiac surgery to see if that will help. So maybe there are some implications for the cytokines that are released post cardiac surgery in neonatal cardiac surgical patients. So we found there were loads of patients who met the criteria but were not diagnosed, and I'm rushing through this in the interest of time, but really what we're saying is about 20% of the patients met 5 of the 8 HLH criteria, were all diagnosed as HLH, but another 30% plus met 4 of the 5, and 3 of the criteria is really not accessible to most immediately, and only half of these patients were diagnosed as HLH, and in a third of these, we couldn't even see evidence that HLH was being considered or hemophagocytic syndrome was being considered. So in a whole cohort of 94 patients, about 30% the diagnosis was considered, made by the treating team. In a fifth, the diagnosis was considered. But in half of the patients, which is a startling number with a high morbidity and mortality, the diagnosis was not even considered. And there are different teams involved, which is why you see this conference having so much interest. Why is it important? Because a third of these patients die. These are a third of these children with high levels of ferritin, meeting 4 of 5 HLH criteria, die. And the mortality in patients diagnosed by treating teams as HLH was lower than the overall mortality. Probably a small indication that if you consider the diagnosis, perhaps you might adopt immunomodulatory therapies, which you wouldn't have otherwise done. So really, not considering hemophagocytic syndrome in children with ferritins of more than 10,000 can be quite costly for the child and the family. And I know Joe Carcillo, who's really a famous intensivist and has done extraordinary amounts of work on this, just published this less than 2 years ago. When and how is hyperferritinemic sepsis, and different from sepsis without hyperferritinemia, and I'd urge you to read this, but he talks about the role of ferritin promoting pro-inflammatory cytokine cascade, particularly with IL-1 and IL-18. So we published this a long time ago. We said, what does this leave the general pediatrician, as Dr. Balasubramanian asked? Okay, if you have a child with fever, cytopenia, coagulopathy, then check serum ferritin. This is in a low and middle income country context. If it's more than 10,000, you're almost always dealing with a hemophagocytic syndrome, then you can take appropriate advice. If it's between 500 to 10,000, then you can look at doing some of the more sophisticated specialist markers. And if it's less than 500, it's not impossible, but it's less likely. At least you're not sitting on a child with hemophagocytic syndrome. And why? Because we're going to come back to this. This was the trial in the 90s of anakinra, which Randy, who's in this call, understands well. Anakinra was trialed in adults with sepsis. It didn't show any efficacy. But when Beta Shakouri and colleagues did a subgroup analysis, they found that when you identify the sepsis patients, and that's what they did, they divided the sepsis patients into those with hepatobiliary dysfunction plus DIC versus those who had one of these or none. And they found that 763 adults were randomized to this anakinra study. And about 43 of them had hepatobiliary dysfunction and DIC, a surrogate marker of hemophagocytic syndrome. So across the spectrum, the 28-day survival was same if you didn't have hepatobiliary dysfunction and DIC. But in those with hepatobiliary dysfunction and DIC, which is essentially a form of cytokine storm syndrome, if you got anakinra, you had much greater odds at surviving. So demonstrating that even in a sepsis cohort, anakinra in a carefully chosen selected few patients will improve survival. I want to finish by trying to demonstrate to you, it doesn't matter what you call it, it doesn't matter whether it's cytokine release syndrome, cytokine storm syndrome, multi-organ dysfunction syndrome, systemic inflammatory response syndrome. Consider them as part of the same spectrum, using terms which are not really diagnostic, but really not helpful. So SIRS and MODS, in my opinion, should be avoided in the intensive care context. And I think immunomodulation for patients in this spectrum should be considered when you have the right biomarkers, such as ferritin at very high levels. And the first criticism that's leveled at a cheap and cheerful biomarker like ferritin is, how do you know that ferritin doesn't go up as an acute phase reactant in any condition? And what I'm trying to demonstrate is, these are two studies showing that in patients, adult patients with trauma, both with and without ARDS, ferritin doesn't cross 1,000. In pneumococcal sepsis, both in those under 75 and more than 75 years of age, ferritin doesn't cross 1,000. So when you see ferritin in several thousands, it's unlikely to be just as an acute phase reactant, but it's showcasing a form of cytokine storm. And that's what several years ago Alan published, and others have now documented, that a ferritin of more than 10,000 is highly specific for hemophagocytic syndrome. So I'm going to stop, and I hope I haven't run over time, with what we published in PIDJ a few years ago with my colleagues to demonstrate to you a sort of algorithm for those who are general pediatricians or infectious diseases or intensivists on when to suspect hemophagocytic syndrome. I use that term hemophagocytic syndrome, call it CRS or call it CSS or whatever else you like. But really, what we want you to do is consider this possibility where immunomodulation may potentially have a role. And I'll leave with this slide and stop there and take any questions. Thank you very much.
Thank you, Professor Ramanan. It was, as usual, very informative, crisp, and crystal clear. Dr. Basraj, you can take questions from the audience. Dr. Chandrika would direct you to the questions.
Yeah, thank you. Thank you very much, Professor Ramanan, for an excellent talk. Yeah, Chandrika, you want to say a few words?
There are questions in the Q&A box and the chat box as well, if you can take that, please.
Yeah. So one of the question is, in a resource-limited setting, what can be the best surrogate marker aside the ferritin to assess the level of cytokine, Professor Ramanan?
Wow, I don't think there's better ones than ferritin. It's not a single marker that's going to make the diagnosis, but if you have a patient with presumed sepsis, with cytopenia, and you've got coagulopathy, if you have a ferritin, as we pointed out in that diagram, of more than 10,000, you're highly likely dealing with a form of hemophagocytic syndrome. The other markers are really hard to get, whether you're, it's not just whether you're in a low and middle income country or even where I'm working, you never get it in time. If you're working like Dr. Henter in Karolinska, then I think you have access to some amazing facilities, and he's been very helpful to me. But really, I think the ferritin in the context of the other markers is really important. And someone's talking about dropping ESR with a rising ferritin. So it's an important question. ESR drop is actually, ESR is a surrogate marker of serum fibrinogen. And so the reason you see the ESR drop in the face of inflammation is because you have hypofibrinogenemia. So yes, a drop in ESR is good, but I wouldn't hang my hat because you may not always get that drop in ESR, and ESR can be affected by a multitude of factors. But really, this biomarker I'd put the greatest emphasis on would be ferritin in the context of cytopenia and coagulopathy.
Yeah, one more question by Dr. Silky Jai. Is the fibrinogen a differentiating factor for HLH versus sepsis? What's the, where do we stand? Fibrinogen.
Well, I don't think there's enough data. So I'll show you later in the dengue talk that it tends to follow hyperferritinemic patients who we suspect have a hemophagocytic syndrome will have hypofibrinogenemia, but it's a relative hypofibrinogenemia. And that's one of the problems with the criteria, because a patient, for example, and the best example is a rheumatological example, a patient with Still's disease will start with a ESR of about 150, will have a fibrinogen of 8 or 9, and then as they go into macrophage activation syndrome, the fibrinogen will drop. But that drop will not be as marked as a primary hemophagocytic syndrome patient who will present with a fibrinogen, which is absolutely in the boots. So I am loath to give absolute values for other markers because a relative drop in the counts, a relative drop in the fibrinogen should be much more profound indicators. Whereas ferritin is an absolute one. Of course, the 500 in the criteria is far too low. But a ferritin of several thousand, you know, I don't think even 10,000 is needed. 5,000 is good enough to in our own series, which is unpublished in Bristol, at least, we find that 5,000 under receiver operating characteristic curves was as sensitive and specific as 10,000.
Yeah, one of the questions from Dr. Devang Pandya. What is the dose of IV methylprednisolone is recommended as per your experience in the CRS? This is one of the common questions in the presently, which is going to be raised.
Yeah, this is an often asked question. You know, there are two mechanisms of action for steroids, as people have heard me say before. IV steroids work mainly non-genomic. Oral 1 to 2 milligrams works in a genomic mechanism. What dose of IV steroid is the right one, whether it's 10, 20, or 30? I don't think there is solid evidence. We use 30 per kilo to a maximum of 1 gram. But I don't think I can say that 10 or 20 is inferior, but I tend to use 30 milligrams per kilogram to a max of 1 gram.
Yeah, one of the question by Dr. Ravi Ambe is from Indore. He is from Gwalior. So what is the role of IV immunoglobulin in CRS?
We don't know is a true answer, but certainly these will come up in some of the cases. The best evidence, which is really only case report evidence, is people have historically used immunoglobulin because that's what they can access. And there's always great comfort in giving immunoglobulin because you think it's not going to harm the sepsis patient, whereas there is a fear in giving steroids, and there is still a reluctance to give anakinra in spite of me showing data that it was trialed in sepsis. Whereas with immunoglobulin, everyone's more comfortable because even if it doesn't cause any benefit, it might not cause any harm. In terms of its actual efficacy, in adult onset Still's disease patient, a group in Switzerland have demonstrated just with IV immunoglobulin 2 grams per kilogram, I think they gave a max of 70 grams, they were able to show resolution of macrophage activation syndrome associated with Still's disease. Everywhere else, IVIG was part of several other therapies that it's very hard to delineate what the impact of IVIG was in the management of HLH as opposed to several things being given at the same time.
One of the questions from Dr. Ravan, in a dengue shock stage where we see a ferritin of more than 10,000 with hepatitis and DIC picture, majority will come out with a supportive care. Does really we need to start a immunomodulation in this type of a situation? What will be your thought on that?
Well, I thought I'll save it for the dengue talk. I think what you need to do is a trial. I don't think you need to take my word, and maybe I'll save the dengue talk for the questions on dengue later on, so that if that's okay.
Yeah, we'll take it in the next.
Session. I think there are quite a lot of questions, and chat box is exploding with questions, and I think most of those questions might be answered during the course of the conference. There are a lot of questions regarding ferritin, its value, its role in dengue, about what we do with multi-organ failure. I think a lot of those questions, I think over the next 3 days, there are multiple talks on similar topics. I guess many of them will be answered over the time. So,
yeah. So,
Dr. Henter might address some of these questions. He's got a lot of experience, so he will tell you some of these in his next talk. And if not, feel free to pepper him with questions as well.
Dr.